All right, so this month's topic for MEC Minute is cyanide poisoning. And this is something that we've talked about probably 5 or 6 years ago, but several of the EMS coordinators asked that we have another discussion about cyanide poisoning, and particularly the cyanokit, which is stocked by some of our agencies. So today what we're going to talk about is why you need to be aware of cyanide, some discussion on what its toxic effects are. And we're also going to review some of the treatment options. And some of the treatment options include medications that have been available for years but really have fallen out of favor. Actually, one of the options that we used to use is sodium thiosulfate. We'll talk a little bit about that as well. And then we're going to talk about when is the cyanokit indicated. So the cyanokit is the current medication that we have in our protocol for the treatment of suspected cyanide poisoning. And, I think we need to have a good idea of when to use it. I'm aware of some runs we've had in the past where patients were candidates for using the cyanokit, but EMS providers didn't think of administering it to the patient, even though it was in their truck, 50 yards from the patient. And the last thing I really want to talk about is how is the cyanokit mixed and administered? So you have to mix it in a certain way. It's not difficult, but it takes a little time, a little bit of effort. So we're going to talk about that as well. So let's start with a scenario. This is a scenario that's going to be fire-based. You have a patient who is in a house fire. They're trapped inside. The first in crew go is in, and they get the patient. They bring the patient out unconscious. They're seizing. They've got the patient on a mega mover. They're moving the patient to your EMS truck. You've got the patient started on IV. They're on a monitor. Oxygen is being administered. And you check a finger stick blood sugar as part of the seizure protocol, and the finger stick is acceptable at 97. You go to using Versed. In this case, you elect to give the patient intranasal and IV Versed, and the seizure stops. But the patient remains non-responsive to painful stimuli. Well, what do you think? Well, if you look at it, and this is kind of more of the graphic I wanted to give you. You've got this patient, closed space fire. They've got sooting in their mouth. They've got facial burns. What are you going to think about? Could this be carbon monoxide poisoning? That's a possibility. You get your RAD-57 out. You put the sensor on the patient's finger. The patient's carboxyhemoglobin or hemoglobin CO is 38%. Normal carbon monoxide in patients is less than 5%. If you have heavy smokers, it might be 7 or 8%. If you look at this guy, this is more than a matter of just smoking too many cigarettes. So true, this carbon monoxide level is elevated, and it's not good, but it really doesn't explain the patient's mentation. Carbon dioxide levels of 40 to 50 can cause confusion, headache, shortness of breath, and vertigo. Over 50 to 60, they're going to be unconscious. But a calculated or measured CO level of 38% really doesn't explain why this patient's unconscious, unresponsive, and having seizures. So what else do you think is going on with the patient? Well, it's kind of a loaded question because, this is a discussion about cyanide. This patient should be considered to be cyanide toxic. So for us in our practices, the most common source of cyanide poisoning is going to be burning of plastics and other combustible items that result in products of combustion that include cyanide. That is going to be our number one potential source. There are also, though, other particular circumstances where you might think about cyanide exposure, and that's chemicals used in manufacturing. And people in these manufacturing situations can have an exposure. So if you go to a plant and you're aware that hazardous materials are used there as part of manufacturing, one of the questions you may have to ask the bystanders or the supervisors, for a patient who's unresponsive or seizing is, could this person have been exposed to cyanide? Do you have a material safety data sheet for the materials around them? Think about, should they be treated for cyanide poisoning? And then terrorism is also a potential source. For those of you who may be old enough, you may remember Bhopal in the 80s. They had a big cyanide leak in a manufacturing plant in India, and thousands of people were exposed and died. Even those who survived had long-term consequences. So you have to think about potential other sources of cyanide other than just products of combustion. So how is this toxin absorbed? Well, it can be directly inhaled, and for our patients, inhalations kind of be the most common. It can be absorbed orally. Typically, patients who have oral exposure to cyanide are patients who intentionally ingest poisons or toxins like rat poison or whatever else that might be out there. So oral ingestions tend to be suicide attempts or homicide attempts on people. You can also absorb it through your skin. Patients who suffer cyanide poisoning, they basically suffer from a metabolic poison. Cyanide attaches to the cytochrome oxidase in cells' mitochondria. Each of your body's cells has mitochondria. The mitochondria are the power plants. They are the parts of the cells that form a chemical called ATP, adenosine triphosphate. It's ATP that gets your bodies moving. It's what provides that energy and fuel for your body to go about its business. So if the mitochondria are poisoning, these cells start dying. And the symptoms that you can see with this poisoning include headache, anxiety, confusion, tachycardia. With ongoing treatment or ongoing exposure and lack of treatment, these patients can become unconscious. They can have arrhythmias. They can seize. They can eventually die. And a significant inhalation poisoning those patients can die within seconds. When you watch the movies and the secret agents have those poison pills tucked into their false tooth, typically it's cyanide. And the other thing to think about in patients with cyanide poisoning, these patients are pink and they are not hypoxic. Their issue is not having an oxygen deficiency. Their issue is there's plenty of oxygen present. The cells cannot take it up and metabolize it. And so they are going to look pink. For us, and in the emergency department, our diagnosis and treatment of cyanide poison is going to be largely dependent on clinical suspicion. You have a patient who appears to be oxygenating. They are having problems with unconsciousness or seizures, but their O2 sats are good. You have to think about cyanide poisoning. Most other patients who are hypoxic or having trouble with circulation, they're dusky and cyanotic. You have a patient in trouble who's pink, think cyanide. Just another graphic. Again, cyanide's a metabolic poison. It blocks metabolism of those cells. They cannot take oxygen and use it to regenerate ATP, which is, again, the cellular material that runs our cells. It's what provides energy. It's really very similar. If you look at why we do high performance CPR, we do high performance CPR to get circulation moving so oxygen goes to the cells and the cells can regenerate ATP, which is what our bodies use to fuel our metabolism. So cyanide is basically a metabolic poison at the cellular level. What are sources? Again, we talked about this. Think about insecticides. Think about photographic solutions. Not many people have home photo labs anymore, but the bigger manufacturers that may be making or printing photographs may have an issue. Really think about it with metal polishing materials, particularly in the industrial circumstance, as well as jewelry cleaners. Acetyl nitrile is a chemical out there used for manufacturing. It can cause cyanide poisoning as it's metabolized by your body. Cyanide is used in electroplating. So if you have a patient who's on the production line at an electroplating plant, think about cyanide exposure. And then synthetic products such as rayon, nylon, and so on, those things are all sources of cyanide poisoning if they burn. A number of years ago, we talked about people using seeds and pits from apricots as a way of treating cancer. Well, the problem is if you eat a lot of apricot pits and other seeds, you can develop cyanide poisoning because cyanide is naturally inherent to those pits. For us, environmental sources, that's smoke inhalation and close space fires, that is the number one source that we're going to see. We in the past or sometimes use sodium nitroprusside in the emergency department or the hospital as a very potent antihypertensive. Typically, patients who are on sodium nitroprusside infusions, we limit their infusion to 1 to 2 days because sodium nitroprusside is metabolized into cyanide, and we don't really want to keep the patients on this medication for more than a day or two. For those of you in the field, it's not an issue unless you're doing interfacility transports. Again, some symptoms of cyanide versus carbon monoxide. If you look at this graphic, you can see that there's a reasonable number of symptoms that are shared. Patients can have headache, nausea, vomiting, confusion, dyspnea, coma, and seizures related to both. But, if you have that RAD57 available, you can check for carbon monoxide. If you're looking at those unique symptoms, cyanide patients tend to complain of chest tightness. Cyanide patients may be a bit altered, more so than carbon monoxide. Patients late in the course of their exposure can develop apnea, tachypnea. Either way, just don't know how they're going to go. They can develop hypertension early and then become hypotensive. They can have a diffuse cardiovascular collapse. And the other thing is, if you have the opportunity to measure a plasma lactate, these patients typically have a very acute elevation of their serum lactate, even though they are oxygenating normally. So elevated lactate with normal oxygenation can be a suggestive indicator of cyanide poisoning. On the carbon monoxide, these patients tend to be dizzy. They tend to be vertiginous with vertigo-like symptoms. They tend to be fussy and irritable. They can have symptoms of flu. So, it's August. We're only a couple months away from the cooler seasons and the furnaces kicking back on. Start thinking about carbon monoxide when you get those runs to the house where patients are complaining of flu. Just as a sidebar, think about CO exposure when you get a call to somebody's house and the whole family is sick with flu-like symptoms. If it all started about the same time, think about CO. Hopefully your CO detectors on your first in bags will be squealing by that time. CO patients also can have loss of consciousness. They can have chest pain, a little bit different than chest tightness, and they may actually have evidence of an MI on a 12 lead. So if you look at it, there's a lot of common features, but your clinical suspicion is going to be what tips you one way or the other. So how are we going to treat this? Well, if it's a smoke inhalation, which we think about first, get the patient out in the fresh air, get them on oxygen, although for cyanide poisoning, oxygen is not going to be a big help. If they have contaminated clothing, get the clothing off. Take care of the ABCs, get them on the monitor. Think about treating with antidotes. We have in the past the cyanide antidote kit versus what we currently have, which is the cyanokit. If you have patients got that dermal exposure, get the clothing off. If it's dry, brush it off. Get them wet and washed off. Keep in mind, if there's dermal exposure, you have to have your own PP in place. These patients can represent a risk to you if you get into whatever materials on them. And then ingestion, if you have a patient, they're unresponsive, there's a bottle of cyanide-containing material next to them. Do not do anything to induce emesis. If they start to vomit, isolate the material, protect yourself, because that vomit, that emesis material can contain cyanide that can be a risk to you and your coworkers. So do not induce vomiting. If you have to place an airway, be careful, because if you have the patient start vomiting on you while you're putting the airway in, you can inhale that cyanide and become ill yourself. So in the hospital, we're going to do a supportive care. We can do a cyanide level, but it takes time. We tend to, get that level back after the fact, after the patient's treated, and we're going to treat them accordingly based on what other findings we have. So again, talking about those treatment options, this is the old Lilly cyanide kit. Used to be a package. You can see it right there in the bottom left. That's how it was stocked in the emergency departments, and it really had three components to it. Amyl nitrate is basically those poppers or snappers, and you could take the amyl nitrate, you can pop it, put it under the patient's nose. You could put it on the reservoir of a BVM if they're being ventilated, and that buys you time. The second drug that is used is sodium nitrite. We give that intravenously. It is basically a chemical very similar to amyl nitrate. It's the nitrite that binds to cyanide and takes it out of, or that binds to hemoglobin and makes cyanide so it can't bind to hemoglobin. It can't be transported to the cells as a toxin. The problem with the cyanide kits and the amyl nitrite and the sodium nitrite is it causes methemoglobinemia, meaning the nitrite binds to hemoglobin so that cyanide cannot. But when you have methemoglobinemia, you also impair the ability to transport oxygen to the cells. So yes, these two chemicals make it harder to get cyanide to the cells, but it also makes it harder for oxygen to get there. So you're not really helping the patient a lot. Sodium thiosulfate is what we used to carry in our EMS bags. It binds directly to cyanide. It makes it an inert substance and can be excreted usually by way of your kidneys and urine. But the problem with it is causes hypotension. So if you have an unstable patient who may also already be hypotensive, you can aggravate their hypotension with this drug. So really, most of us consider the cyanide kit to be a dinosaur. I don't think the hospitals even carry it anymore. And it's really not good for smoke inhalation, like I said, because that methemoglobinemia that's caused by amyl and sodium nitrite prevents oxygen uptake and delivery to the cells by hemoglobin. So, you're basically substituting one poison for another. So that's why we're not using it anymore. So the cyanokit, that's what we currently use. It's a medication. It's basically a precursor to vitamin B12. And it's basically hydroxycobalamin, which is the chemical name for what's in it. And it binds to cyanide. By binding to cyanide, it forms cyanocobalamin, which is vitamin B12. So you're taking a dangerous chemical, binding it with a relatively inert chemical, and forming B12. This is non-toxic. B12 is excreted in the urine. Your body has limited capacity to store B12, and so as long as you're making urine, the extra B12 your body doesn't need is going to be excreted in the urine. The other thing is this chemical, this cyanokit, is safe for use in smoke inhalations patients because it does not worsen hypoxia, does not aggravate oxygen delivery to the cells, and it's also safe for use in pregnant patients. There's a study out there that was published a while ago, the Paris Fire Brigade. They used this chemical for smoke inhalation patients in cardiac arrest. And for those patients in cardiac arrest without burns or other injuries incompatible with life, they had a 50% ROSC rate. That is phenomenal. That is very good. A couple years ago when we first started using cyanokit, there was a YouTube video out there that showed three young women who were in a shared apartment. They were trapped because of a fire. One was brought out in cardiac arrest. The other was significant smoke inhalation. They all three got the cyanokit, and they all survived to hospital discharge with normal mental status. So this kit does work. The one thing we have to understand with the cyanokit, though, is it's not used often enough as part of studies to come up with, the highly statistically significant numbers we would like to see to justify or say that truly is the greatest antidote ever developed. But we know it does have a positive effect by experience on helping patients. So if you like, I got a little fast in my head of myself, but our dosing schedule is 5 grams IV over 15 minutes. 5 grams is one vial. If the patient needs a second dose, it can be readmitted. A second dose being given. Typically, that's in the emergency department, and typically we don't have a second dose available. If you have a child, you can use it to children of any age. It's 70 milligrams per kilogram for a maximum of 5 grams. Regardless of how much you're going to give the child, that dose is also administered over 15 minutes. So it doesn't matter whether it's a 10 kilogram child or a 50 kilogram child. The dose that you calculate is given over 15 minutes. So very safe. So the biggest side effect of this medication tends to be change in their skin color, but it's a very safe medication to administer. So for us, what's our indications for cyanokit? So if you look at our protocol under the toxic exposure page, cyanokit is indicated for any patient who is a victim of smoke inhalation, who was exposed to smoke or fire in an enclosed area. They have soot around the mouth, nose, or back of the mouth, and they have an altered level of consciousness. So they're confused, they're disoriented, they could be agitated. So if the patient meets all three criteria, they are a candidate for the kit. We have a couple other potential candidates for the kit. We also have a firefighter down at the fire scene who was active during suppression or overhaul. The chances are they were protected, but if they go down, you find they're in arrest or they meet any of these other criteria like altered level of consciousness, consider administering the kit. And then the other indication for the kit is any suspected intentional or accidental cyanide poisoning. So if you go to an industrial site, patients involved with electroplating, cyanide is used as part of the process, and now they're altered. Now they're having symptoms of cyanide exposure. Treat them with the kit. It's a bad exposure. It's a bad chemical. It's a bad player. Give them the kit. It's safe. Yes, it is costly, but don't worry about the cost. You have a patient who needs the drug and you've got it available, give it to the patient. You have a patient, you go to their home, there's a bottle there, it says of a drug or a chemical that indicates cyanide poisoning, use the kit. Protect yourself, use the kit. So side effects of this drug, really pretty innocuous. Sometimes patients can develop hypertension related to the kit. It's not dangerous. Matter of fact, if you have a patient who's suffering from smoke inhalation and cyanide exposure, they may be a little hypotensive anyway. A little extra boost in their blood pressure is not bad. So regardless of what their blood pressure is, if they are a candidate for the kit, give them the kit. The other thing you'll notice is patients will get this really red complexion. And that's because you're giving them 5 grams of this red stuff. And it's going to change their complexion. Once the Foley catheter gets placed, assuming they need one, or when the next time they urinate, the urine's going to be red. It's going to stay red for a while. The last thing that we have to be aware of is that it can mess up lab analyzers or any analyzers that are using photometrics in order to make calculations. So blood gas analyzers to measure the patient's chemistries, like a basic metabolic panel. It can mess them up, but it's I think better to have a live patient and not be able to do some of the lab work than being able to do lab work, but you have a patient who's going to die. So if you have a patient, give them the kit. When you get to the hospital, let them know that the patient received the medication, and they may be able to make some adjustments in the testing and the processing of the lab samples. I know in the past couple of months we had a patient get the cyanokit. They went to East. They did well. It seemed that the chemistry analysis really wasn't that messed up. So somehow the clinical chemists were able to make up for it. So I think the last thing to talk about is the kit available? So the kit is optional to be stocked by your EMS agencies. When we first started this, our goal was to have the kit out there in select vehicles, battalion vehicles, whatever, with the idea that it'd be a shared resource. But we have it out there as an optional kit. Currently, Columbus Fire doesn't carry it. So if you go on a fire run with Columbus and you have a smoke exposure patient, and you're the EMS provider on scene, feel free to use the kit. But don't expect Columbus to get it out of their EMS supervisor vehicle because they don't carry it. Some of our agencies have it as a shared asset. So in Fairfield County, Pleasant Township carries it on their rescue and their second due engine, so it's available there. The thought being that the rescue's on most of the working fires in that area of the county. I believe Lancaster has it on their command vehicle. In Franklin and Licking County, it's on certain vehicles based on each department's preference. But I think it's important for you to know, as an EMS provider, regardless of which of the 15 entities you work for, who's carrying it. Is it on your truck? You see it every day when you do your medication check. Is it on your command vehicle? Is it on a shared resource with another company? So think about where is it, know where it is, and talk with your EMS coordinator if you don't know who has it. Because what we don't want is to have a patient who is a candidate for the kit. They're in distress. The kit's available, but we just don't know it's on scene. Know what your resources are. So that's my quick and dirty on the cyanokit. If you have any questions, feel free to reach out to me. Hopefully, you know where it is. If you have any training needs, let me know, and I can work with your EMS coordinator on this. Thank you.